So rabies is an infection that's transmitted from animals to humans, generally through saliva of an infected animal through bite transmission. Non-bite exposure is possible, but extremely rare. It is important to keep in mind though, that especially when we talk about bats, the bites are not always visible and can be small. So which obviously is the pharmacist, I'm here to kind of talk about post-exposure prophylaxis. And first of all, when exactly should we give it? Rabies is exclusively restricted to mammals. So particularly those woodland creatures that are carnivores like raccoons, skunks, foxes, coyotes, bats as well. Rarely rabies is transmitted through pets, mostly because of vaccination programs. And while livestock, rodents, and lagomorphs, which is just a fancy word for rabbits and things in the rabbit family, are mammals, they very, very rarely are vectors for rabies. As I said, exposures that require PEP are mostly bites because it's saliva getting into the skin. However, exposure to saliva and brain matter through any sort of open cut or wound can also technically transmit rabies. People who don't require PEP, if you were just petting or handling the animal, if you had contact with blood, urine, or feces, or if you know that it was the saliva or brain matter came into contact with intact skin, although that can be difficult to figure out. Again, any bat bite should be treated, mostly because bat bites are very tiny and cannot often be seen. So that's why we treat so many just kind of bat exposures. Here you'll see a chart that lists the different type of animals and what the current CDC guidelines are. Keep in mind that for a lot of these, consulting your health department can help determine whether or not rabies post-exposure prophylaxis should be given. Rabies post-exposure prophylaxis consists of two parts: the immune globulin, which gives immediate immunity, and the vaccine, which actually gives kind of delayed, more permanent immunity. The immune globulin is given as 20 units per kilo. If possible, the full dose should be given into the wound, and we'll talk through a couple scenarios in a minute. The dosing for HRIG is the same in both adults and in pediatric patients. It has a very rapid onset of action and lasts for about 21 days, which is why you need to give both the immune globulin and the vaccine. It should not be given above that 20 unit per kilo dose because any higher levels of HRIG will actually diminish the patient's response to the vaccine. It should also be given only once in a lifetime. So once the patient's gotten RIG and been previously vaccinated, you don't need to give RIG again in the future, which stands for rabies immune globulin. And you should never mix it in the same syringe as the vaccine because it will inactivate the vaccine. The second part of post-exposure prophylaxis is the vaccine called Rabies. It is a 1 ml injection intramuscularly. It should always be given in the deltoid. In very small children, it can be given in the outer aspect of the thigh, but in adults, it should always be given in the deltoid. And if we don't give it there, the health department will call us and potentially call the patient back in, which creates a lot of headache. So always vaccine in the deltoid. And again, same dose for both the children and adults. The onset of action is 7 to 10 days, and that is why we need to give both, so that the immune globulin is working while the vaccine has time to work. You should never administer it in the gluteal area, so into the actual gluteus maximus, because that has been associated with treatment failure and lower antibody titers. Also, again, never administer it in the same site as the vaccine, or sorry, as the immune globulin, because it will inactivate, and never in the same syringe. So if you have a patient that you need to give a large volume of immune globulin to, as I said, it should go primarily into the wound. However, the remainder can go in a number of sites. So one deltoid is taken up by the vaccine. You can put up to 2 ml in the opposite deltoid of wherever the vaccine is. You can put 2.5 ml in both the upper and lower vastus lateralis on both sides, so the outer aspect of the thigh. And then you can use the ventral gluteal muscle as a last resort if you absolutely have to, which is kind of that muscle here, kind of on the side of your hip. So again, never the gluteus maximus. So just to kind of walk through some scenarios to help you better understand how you should give vaccine, these are some commonly encountered scenarios. So if you have a dog bite, which to the lower extremity, that's often going to be a very large open wound. In those cases, you just give the vaccine in either deltoid. And then all the immune globulin can be given kind of intradermally all around the wound. I would suspect usually with those kind of larger dog bites, you're able to do it the exact way that you're supposed to with all the immune globulin into the wound. Now let's say you have a smaller cat bite in the hand. Often cat bites are in the hand. It's going to be a much smaller bite. It's unlikely you're going to be able to put all the immune globulin there. So if it's in the left hand, you're going to want to put the vaccine in the right arm so that we can still administer immune globulin onto the site of the wound. You would put a little bit around the wound, and then if you have excess, go for this deltoid first. So again, you're still anatomically as close as possible, and then any remainder would go down into the outer thighs or the ventral gluteal if you still have additional immune globulin left. And then last, another common scenario that questions come up about is bat bites. Bat bites, as I said, there's usually no bite where you can actually put the immune globulin in. So for bat bites, you're just going to put your vaccine in either deltoid, and then I would start with the outer thighs because you can get up to 10 mLs in there, and then any excess you would do the deltoid opposite where you gave the vaccine, and then last case scenario, if you still had more immune globulin, would be your ventral gluteal. Now they make a more concentrated form of the immune globulin, so it's usually unlikely you would have to get to the point where you need to use the ventral gluteal these days. The overall vaccine schedule for a patient who's never been vaccinated for rabies before, they get immune globulin on day 0, and then they also get first dose of vaccine that day, and then they get subsequent vaccine on days 3, 7, and 14. For patients who are immunocompromised, they get a 5th dose of vaccine on day 28, and immune-compromised individuals also need to get a test of antibody titer to make sure that the immunization was successful. For patients who've been previously vaccinated or maybe had pre-exposure vaccinations, such as veterinarians or other patients like that who may have had vaccine in the past, then they do not get any immune globulin, and they simply get a vaccine on day 0, so the day they see us, and then later on day 3. A couple things to end on: what happens if you have any sort of missed doses or delays. So if you have a delay in starting HRA treatment, of course this is a medical urgency and treatment should be started as soon as possible. However, there's no kind of limit on when you should give someone HRA. So even if it's been 2 weeks since the bite, you can still do post-exposure prophylaxis because there have been reports of delayed onset of rabies. The other thing is if the vaccine was given, but the immune globulin wasn't started, as was the case back when we had a immune globulin shortage a number of years back. Even if they get the vaccine on day 0, you can still give the immune globulin up to day 7, keeping in mind that the vaccine doesn't work for 7 to 10 days. So they're still at risk for developing rabies at that point. So even if they present to you, they got a vaccine somewhere, but they haven't gotten immune globulin, you can give that up to day 7. And then as far as Rabivert, if we start giving the vaccine series, every effort should obviously be made to keep the vaccine schedule. Generally, if a single dose is missed by a day or 2 and they kind of get off schedule, it shouldn't be a big deal. However, there's really no data on what happens if they miss or get off the schedule subsequently. And those patients, if they get way off the schedule, should again be tested at the end for antibody titers to make sure that it was successful. That being said, once they do get off by a day or 2, the rest of the schedule should be adjusted. So if they were supposed to come on day 3 and they didn't come until day 4, then the day 5 vaccine should be given on day 6. The day 7 vaccine should be given day 8, and so on and so forth. And that is pretty much rabies in a nutshell. So with that, I'm all done.